Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, listeners. This is Kevin MacPherson, and today we are going to be interviewing Debra Roberts regarding her manuscript titled Treating Mechanical Joint Dysfunction in Children, a retrospective exploratory report of selected cases. And this manuscript was published in 2022 in JMMT. Now, some of you heard within that title the children portion of it. This is a little bit different than our average interview. However, it's not the first pediatric-centered piece. We do go all the way back to episode 8, where our very own Antigone Fissi was interviewed regarding an orthopedic case for, I believe, a 6-year-old for that specific one. Now, getting back to this article, what you're going to see is that Deb is not an orthopedic manual physical therapist by training. She's a pediatric therapist, but she noticed a lot of difficulties that fit more within that musculoskeletal world. And subsequently, she decided to start applying manual therapy techniques to these patients. And the bulk of the patients are not the more neurologically involved. They are individuals who have things along the spectrum disorder. They have difficulties with development, attention deficit. So there's a lot of interesting interplay within this manuscript. But I'm not going to go into that. We're going to get into the interview to really dive into that. So without further ado, here is our interview with Deb Roberts. Hi, Deb. Welcome to the show. And let's just start off with getting a little bit of background on you and why you felt the need to write this article.
Okay, thanks, Kevin. I am a bachelor degree physical therapist, and I was in practice for 45 years until I retired when COVID hit. And I've always been in pediatrics, and I've always been interested in manual therapy because even back in the 70s, my college actually had beginning information on it and practice. So my main reason for writing the article was that I wanted more PTs to use manual therapy on children before I retired. And I had been doing small group training sessions and teaching, and I trained in 2 therapists to take over at my last practice so that they could continue doing the manual therapy. But I didn't feel like I had a lot of interest, or maybe it's that I didn't find a lot of pediatric therapists feeling comfortable doing what I was teaching. So I tried the article and it got published.
So that's very interesting. Do you find that there's any type of hesitance for practitioners to pick up this addition of manual therapy to this population?
Definitely. When my own children, 3 of them, had sports injuries, they're all like 3 sport athletes and always injured, I would choose orthopedic manual therapists to treat them with great success. So I could recognize musculoskeletal conditions in the children I worked with, and I would try to bring them to the adult therapist because there were no pediatric manual therapists, and I had 0 success. So anyway, my own children with orthopedic issues and no other diagnosis had no problem getting manual therapy done, but the pediatric patients that I was working with, I guess, were frightening. And some of the adult-oriented PTs that I went to said they were afraid to touch a child, afraid they'd hurt them, weren't sure how to handle the evaluation. I don't have any advanced training in manual therapy. And what I think I know is that you need to have a consistent response and alert person who can communicate where pain is or the problem area. And the children I was bringing to these manual therapists could not do that. So that's why I had to do it. And that's how I got started in doing it myself.
So that's very important to kind of point into. You saw the need with the population itself. You didn't have this perceived threshold that you have to be an expert in manual therapy to start delivering care to your patients, which it seems like some of the practitioners felt that they needed to have extra training or were afraid of touching patients. But I really enjoyed how you brought that mix, and you were very clear in your article. You were very clear in setting up this, that you didn't have a lot of this advanced training. And I think that's something that I really hope our listeners latch onto, is that while advanced training is nice, you really just need to deliver what your patients need, right?
The pediatric therapists that I work with, once I started having outcomes that were shocking me, I was teaching other pediatric therapists, and I have yet to meet one that has any advanced training in manual therapy. So they were more receptive to my training and trying it, and I got really good feedback, but then there were only a handful that continued using it, and it seemed like they were just lacking confidence because of fear of not having advanced training, just what you said. I mean, you're doing something that isn't in the literature. It's not the gold standard for pediatric therapy. And I guess I've been a rebel forever, so I just did it because it worked.
When I reflect on your story, I kind of think of the process in the US with manual therapists really going back to the manipulative, the high velocity, low amplitude techniques, and how really they needed to pop everybody on the head who was teaching across all different areas of orthopedic physical therapy to say, no, all of the data says that these are safe techniques, despite what they appear as. And I mean, it took a long time for just the general orthos, without considering things like epiphyseal joints and all of that stuff, to kind of latch back onto it. So it sounds like a very similar fight that you're on.
Well, just rationally, if you watch kids playing on the playground or on their equipment, bikes, etc., the force they inflict upon themselves is far greater than any force that I could or would apply to them. So that observing that made me feel more confident in doing the manual therapy that I do.
I think about the number of times that I've had to talk to students, I've had to talk to patients about some of the hands-on techniques, and really just pointing out that they have more force going through their spine, just going from supine to standing, than what we could possibly deliver with our hands. So I think that's a really good point to bring up to the audience.
Right. Just thinking about why pediatric therapists are hesitant to try these techniques, even when their colleagues of mine respect what I do, refer their children, patients to me. It still seems to be fear, partially because there is no research or not very much research on doing manual therapy on kids, and it's taught differently in the school system. There isn't a section on manual therapy for children. It's the neurological component for kids. So,
and that was something that did come out in the case. You made sure to have a sentence that pointed that these children were not the more neurologically affected children that probably come to the average listener's mind when they think pediatric physical therapy. Was I interpreting that correctly?
Yes. The patients I selected were selected because of where I worked at the time. So I've seen the whole range of pediatrics in my career, but the last 15 years was in an OT clinic where I had set up their physical therapy program. And by that time, I'd become comfortable in treating the musculoskeletal impairments, either perceived or not perceived first, and then working on that's neurophysical too, but then it frees the body up to be more, to make my other skills more effective, like working on motor planning and motor control work, repetition. But the musculoskeletal impairments had to be treated first. So that's how I approached the last 15 years of my treatments, with far better results. And so prior to that, I was still using these skills, but irregularly. And my patient population typically had spasticity, cerebral palsy, stroke. And these techniques were very effective with them too, because if you can imagine the stiffness that comes with spasticity, of course, you're going to have musculoskeletal impairments, you're going to have pain. The results may not have been as dramatic observationally, but the patients were thrilled because it decreased pain where there really isn't any other effective pain treatment. And their PCAs, caregivers, I would teach them these techniques because they're so simple. And those were the people that followed through because their clients were in pain, or they walked better if they had this done daily. Whereas the less neurologically impaired children didn't need to be treated on a regular basis. And that was the biggest difference.
Yeah, and that was a part of the article that it makes absolute sense when I read it, but until I read it, I wouldn't consider it because I think it was TL, which most of all the cases were kind of provided in the context of their initials or pseudo initials. Where it mentioned because of some of those impaired motions that you saw, there was some difficulty with interacting with their peers and potentially problems with achieving the appropriate level of motor coordination. And I was like, I would have never thought of that on my own, but when I read it, I was like, that makes absolute sense.
Well, I learned more from the last 15 years from my patients than I did my whole 45, because I don't know if I'm unusual, but my friend PTs don't typically look to treat these types of children with ADHD, autism, developmental delay, because we didn't think we had much to offer, I'm guessing. And so I just did it because I was setting up the PT part of this OT clinic, and the OT saw what I was doing and just started sending me. So these were self-picked from their OT population because I told them what I was looking for. Impaired coordination, balance, fatigue, impaired running. I came up with a whole list of what the OT should look for and send them to me, and then see if I treated them for the musculoskeletal impairments to see if when they came back to OT, they could better reach their goals faster and easier. And then I found out how many kids really have pain that impair their function. And that was quite an eye-opener, because in the literature, maybe not longer than 10 years ago, it still said children under 12 didn't have pain. Now I think we're down to 8, but I know this from fighting with insurance companies to reimburse me.
Yeah, another time, another talk from a reimbursement standpoint, insurance companies for certain. Now, one of the things that listeners love about case series and cases is there is a little bit more specificity in what was provided to the patients in there. And in yours,
Uh-huh.
you had several pictures of the specific techniques that it wasn't the patient gets all of these 10 or 11 techniques. It was they got what was matching to their impairments. Was there something specific about the techniques that you chose or that you use that pointed you towards them, or were they just the ones that were most comfortable for you?
Definitely the latter. That's all I knew. So I had a few techniques for SI joint dysfunction, and they involved, exact innominate rotation, understanding sacral rotation, and that was too confusing. So then I just used those techniques for the entire pelvic ring, because I figure if one side's off, the other one has to be off. And from there, I observed a local PT who will treat children, and he uses manual therapy almost exclusively. And I observed him working on my own adult children or teenage children. So by observing him, I put in the leg pull and some PNF patterns. And then I guess I got my underlying philosophy from Kelly Lynn Roberts, DPT, who's local at Fix It PT, and she explained why my techniques were working. So I did put the cart before the horse. I have a very limited amount of techniques at my disposal, but they work with kids. I won't say they work as well with adults, and so I refer them to Jim Olson or Kelly Roberts Lane. So then the ones I picked for the children, sometimes I do the exact same thing all day, but the results are totally different because every child comes with a different history and a different need. But these simple techniques, just this short list, work. So I don't bother to do the foot if their feet look fine. I usually have them start running and frog hopping and observe. And then I decide if it's a lack of trunk rotation or ankles, toe walking, and then I pick.
So as you're going through it, I have to think about the history of manual therapy and orthopedic manual therapy. And, all of it came from somebody putting the horse before the cart, or the cart before the horse. In that, it was just kind of like, let's try it. Let's see what happens. And slowly over time, people started to say well, it looks like this works better for patients that look like this. And I also go back to what a lot of my mentors have said, and a lot of what my mentors and myself do. And that's kind of like, you got your 2 to 3 really these are my home run techniques for this area. I got other ways to kind of get in there, but these are the ones I use on almost everybody, and I use them based off of response. So it sounds like within your career, you've done pretty much the same evolution that an entire field has. So
interesting. Well, one of my first patients really hooked me because I think he was about 9 years old, and he was going to OT again for sensory problems. Everyone had trouble with him because he just constantly talked about pain. So he got a label as overly sensitive, and they even used the words in the chart, obsessed with discussing pain. So the OT sent him to me, and I talked to him, and he hated gym. He said he was the slowest runner in the class, and he would love to do sports, but he's not good at them. So this was all self-described. Then he said the pain runs from his neck down to his legs, and it felt like electricity. And so he was sent to OT for sensory problems. Anyway, I treated him. I think he had, I have it written down, 3 treatments in 5 weeks. And after that, he had no pain. This is all self-described. He said he was running as faster than everyone in his class. He was winning at games. And then months later, I ran into his dad, who said he was now the best runner in his class. He was discharged from OT as soon as I was done with him because he suddenly had no sensory problems and no need for OT. And then later I got the history that he fell on a box fan off of his top bunk when he was 4. So it all put it together, but that really started me using this primarily in my work.
What you're describing is really that patient-centered care that we all should be striving to go after, and using techniques that work, and using an appropriate amount of timing. And I remember when I pulled this article and I saw it, and I said, like, why would I have a pediatric therapist publishing in JMMT? And you are hammering home all of the things that, in my opinion, and many other all therapists should be doing. So kudos to doing that. And I really do hope that this discussion in your manuscript does tend to stimulate more research into the treatment of orthopedic problems in much younger patients than what most of us are comfortable doing.
Yeah, that would be wonderful. And also looking at those kids that we say, maybe we say they're soft signs, or we don't think of them for PT, autism. It's amazing how coordinated they suddenly become when the musculoskeletal system is looked at. And I think they should be at least given a chance, because self-esteem is huge. Can I tell one more story? Do I have time
Yes,
for a
please.
story? Well, this one boy, I'm going to say he was in later grade school maybe, and his self-esteem was terrible. He was the last one to come in gym class running. He couldn't play sports. He couldn't keep up with his family when they walked in the park. And he was miserable because he had no friends. And this was all self-described again. So I worked with him. I don't remember the details. I didn't write these down, but I just remember the self-esteem part. So I treated him again, probably 2 or 3 times. And his dad came in and said that he had run out onto his cul-de-sac the day before and knocked on every door and asked the kids to come out and play. Himself, he initiated it, because he could now run, he could ride a bike, he could ride a scooter, and he could do something with the kids outside. And so sometimes those stories break my heart, but if more PTs could see them and treat them, that self-esteem and confidence is huge. So,
and I believe that is a huge point to start to bring the podcast interview to a close. Life-changing interactions with our profession and these patients, and you have really brought out a huge area that our profession has had a deficit in. And I thank you for bringing forward your manuscript, and I thank you for being brave. To know that your background isn't kind of in that world of like, you've got to be ultra specialized to bring that information forward. I know it's probably not the easiest thing, but I think it's very important. I think it's very necessary. So I thank you for doing so.
Well, thank you so much for getting the word out and helping me get more of these kids treated. I can't tell you how much I appreciate this. Thank you.
Now, Deb, I'm sure that we're going to have some people that would like to follow up and get a little bit more information and some ideas. Is there a better way for them to reach out to you if they have more questions?
I think my email's the best. I'm retired now, and I just use my personal email a lot. It's Deb Roberts, DEBROBERTS, then the number 2 @gmail.com.
Perfect. And we'll have that in the show notes, as well as some links to all of the things that we can for the listeners. But Deb, thank you so much for joining us today, and I hope you have a wonderful rest of your day.
You too. Thank you, Kevin.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.